Hi, my name is Hoon Choi. I'm a neurosurgeon who specializes in spine surgery at the Cleveland Clinic, Florida. Today, I would like to talk about the topic of minimally invasive surgery for spine surgery and how it is able to reduce collateral damage in the spinal musculature and in the posterior tension band. So, simply put, minimally invasive spine surgery does not come down to the length of the incision or even the number of incisions. It is a way of thinking. And the way of thinking is that in order to correct the spinal pathology, we should be able to get to the pathology in a manner that minimizes collateral damage. Now, minimally invasive spine surgery may also mean that the most minimally invasive way may be that it is no invasive surgery at all. So I would first like to emphasize that the management should first consist of conservative management with our multidisciplinary colleagues who serve in NASS and in the spine care community, comprising of different therapists in physical therapy, chiropractors, and pain doctors, medical spine specialists from PM&R background and also anesthesia background and even interventional radiology. Now, in some cases of spinal oncology, it may also involve radiation oncology and medical oncology. With that in mind, I'd like to talk specifically about how minimally invasive spine surgery is advantageous in preserving the normal anatomy. Now, the first goal of surgery should be to go and usually to decompress some neural elements, and in some cases to remove space-occupying lesions or some neoplastic lesions or some benign processes. And in some cases, it may be spinal stabilization by way of instrumented fusion, or in some cases, putting in motion preservation devices such as artificial discs. Now, in order to get to the desired anatomy, traditionally, the way has been through a midline incision, and in some cases, that is still the case. That is a gold standard. The way that minimally invasive spine surgery has evolved, it is with the paradigm of preserving the paraspinal musculature. So if you think about the midline incision and the traditional approach that requires subperiosteal dissection, which devascularizes the paraspinal musculature and then subsequently leads to necrosis of the muscles, and in some cases, after removing the structures such as spinous processes and the laminae and some facets, the muscles, they don't really have anywhere to attach back to. And that could be a problem, especially if one was to receive a decompressive procedure without the fusion component. So, for example, if you're carrying something with your hands, it is easier to carry that with your hands closest to your body rather than with your hands stretched out farthest from your body. So that's the simple physics. So if you think about a seesaw and a fulcrum, if you're calculating, I don't know if any of you are car enthusiasts, torque, so it's measured in pound-feet or Newton meters. So the component there is the distance. So if you think about some of the unfavorable spinal biomechanics, as we go up in BMI, some of the truncal obesity can move and affect the weight distribution. So if you're carrying more weight anterior to the spine and further away from the spine, it increases the work that needs to be done for the paraspinal musculature. Because if you think about the spinal column as the fulcrum, and how much weight you're carrying in front of it, that has to be counterbalanced by the force that is behind the spinal column. So the distance behind the spinal column, where the muscles are, it is very close to the spinal column. It is attached to the spinal column. So it has to be able to exert and contract and pull your spine so that you don't fall forward. So in order to be straight. So if you think about that with that in mind, and if you realize how important these muscles are, the multifidus, longissimus, and how they are crucial in stabilizing the spine, then maybe we should think twice about preserving these muscles when doing any kind of surgery. So the minimally invasive spine surgery can be with a large incision, but in some cases, such as trauma or some spine oncology cases, the incision still may be better off being the midline incision, the traditional way. However, preserving the fascia, preserving the musculature underneath is what's important. And on the other hand, the incisions may be multiple and small, but if the damage under the skin is significant, that is not truly following the preservation of the structures that are important. So, and the endoscopic technology, the techniques, the tubular the techniques, robotics, augmented reality, navigation, all of these enabling technologies can be used to assist the surgeon and the surgical team to achieve the goal of preserving the structures that are not your target. So, in other words, the minimally invasive spine surgery is a way of thinking, and in some cases, an obsession, but it's not just about the incisions, but it's about preserving the anatomical structures. And also, sometimes, if minimally invasive spine surgery exposes the patient to additional anesthetic risks by prolonging the duration of the surgery excessively, it may mean that the surgery may have to be performed in a traditional open manner. So it is it's a holistic way of thinking in preserving the anatomical structures, but also thinking about minimizing the risk for the patient.